So thank you for coming to this talk on Friday afternoon about why I think that the World Medical Association has to revert to it's not their initial position on placebo-controlled trials when there is an established therapy. It is one of their earlier positions. So what I'm going to do is I'm going to share my screen because I've got some slides. Here we go. And then I'm going to do play from start. So now I'll count on someone to unmute themselves and shout if they can't see the slide. I'm Jeremy Howick. I'm a member of the Faculty of Philosophy and a proud fellow at Kellogg College. This is a story about Phil. Phil drank too much whiskey for too many years and had alcoholic liver disease. Now, we've known since the 1990s that steroids are effective for treating alcoholic liver disease to some degree. They even prevent death, to some degree, in about 20% of people. Now, in the early 2000s, so 10 years after we already knew steroids could help, a new drug came along for treating alcoholic hepatitis. To get it approved, the drug companies had to test it in a trial, of course. And the drug company representatives paid Phil's doctor to help with the trial, and Phil's doctor suggested that Phil enroll in the trial. Phil had a vague idea of what a clinical trial and a placebo was, but he trusted his doctor's recommendation and signed up for the trial. Yet instead of comparing the new drug against steroids, what we already knew worked, they compared the new drug against a placebo. Like most patients in trials, Phil didn't fully understand what the trial was about or what the placebo was. This is because the information sheets patients get when they enroll in trials are often incomprehensible to non-specialists. Phil ended up in the placebo group and died. Now, had they compared the new drug against steroids, there was a 20% higher chance that he would have lived. Phil is not a real patient. It's a fake patient. But the trial of the new drug against placebo was a real trial. And there were real patients like Phil in that trial. This trial I just mentioned is not unique, quite sadly. We did a study of all placebo-controlled trials published in 2015 in the 5 highest impact medical journals. We found 70 placebo-controlled trials. Now, 66 of these trials were in indications where there was no established therapy. So there was no kind of equivalent of the steroids for Phil, where we knew we could have compared the new drug against something that we knew worked. But 4 of them used a placebo control in spite of there being an established effective therapy. I only found 4 in 1 year, but this is, of course, is just the top 5 medical journals. If I were to expand my search to, the top 30 or 40 medical journals, we would have found many, many more. Just every chance we would have found many more. Now, these trials appealed to the Declaration of Helsinki, which you'll see states that they can do that kind of thing. That is, use a placebo control, even if there's an established therapy. I think these trials are unethical. One of the pillars of medical ethics is the principle of beneficence, to help when you can. Another pillar is non-maleficence, do no harm. These suggest that these trials are not ethical. Yet, as I said, these trials cite the gold standard of ethics, namely the World Medical Association Declaration of Helsinki, or at least the new version. Because in 1996, the World Medical Association Declaration of Helsinki, or I'll just call it the Declaration of Helsinki from now on, they banned placebo-controlled trials if there was an established therapy. Here's a quote from that version of the declaration. In any medical study, every patient, including those of a control group, if any, should be assured of the best proven diagnostic and therapeutic method. This does not exclude the use of inert placebo in studies where no proven diagnostic or therapeutic method exists. So of course, if there is no proven beneficial treatment, then of course, it's often okay to use a placebo control. The issue is, if we know there is a beneficial treatment that's proven to be beneficial, that has to be the control treatment, or so they said in 1996. This Declaration of Helsinki, of course, was born out of the Nuremberg Code produced in 1947, which arose as a reaction to the unethical experiments conducted by the Nazis. One quote from the Nuremberg Code is, "The experiment should be such as to yield fruitful results for the good of society, unprocurable by other methods or means of study, and not random and unnecessary." But of course, we can achieve the goal of knowing whether a new treatment works by comparing it to an established one. So that would be a violation of the original Nuremberg Code, as well as the early versions of the Declaration of Helsinki. Then in 2008, they revised the Declaration of Helsinki. This revision actually started with a bit different wording in 2004, but it came out in clear in black and white and a red underline for the slide in 2008. They said that you can use a placebo control even if there is an established therapy. Here's the words. There's, "For compelling and scientifically sound methodological reasons, the use of placebo is necessary to determine the efficacy of safety of an intervention." So they're allowing, they say here above that, the bullet point states, the use of placebo is acceptable in studies where no current treatment exists, or when you need it for what they call compelling and scientifically sound methodological reasons. Now, perhaps what was unsurprising to me is they didn't state what those apparent methodological and scientifically sound reasons were in the declaration. There were no references. A big problem, of course, before I go into try to tell you how I found those reasons, is it puts clinicians in competition with statisticians, because the clinician, their duty is to do no harm, to benefit the patient. This precludes the use of placebos if an established therapy is available, established beneficial therapy is available. Then these sound so-called scientific and methodological reasons are saying, no, we need a placebo control, even though there is an established beneficial treatment. It seems to put, the tension between clinicians on the ground whose duty is to their patients and these statisticians or researchers who are appealing to these so far nebulous scientific and methodological reasons. Now, this raises the question, what are these reasons? Well, they don't provide them, and I think it's an example of unethical behavior by so-called ethicists, because they are not being transparent about the ways in which they developed this guidance. But I did do some digging around, and there are basically two main sources that I found, academic sources that seem to have informed the revision to the Declaration of Helsinki. One is a series of two papers published by Robert Temple and Susan Ellenberg of the US FDA. And the other one is an International Conference on Harmonization E10 guidelines, which Temple and Ellenberg were also authors of. Now, in that series of three documents, they claim that they say there are two basic so-called scientifically sound and methodological reasons for why we need placebo controls. One is called the assay sensitivity argument. The other one is that they say only placebo controls generate absolute effect sizes. In fact, there are two versions of the assay sensitivity argument, but one of them is rather obtuse, and I point people to the paper I published for more details. It fails quite trivially, in my view, once you look at it. Let's look at it more closely. So let's be charitable first. Assay sensitivity is the ability of a trial to distinguish between an effective and ineffective therapy. That's one of the interpretations that I'll be focusing on. Now that's very important because here's an example of poor King Charles II, who was basically killed by his doctors. Here's a quote from the doctor treating him. He said, the patient, namely King Charles II, regained consciousness. The doctors were ecstatic. Surely the king would benefit from more bloodletting. So 11 consulting physicians decided he would benefit from more bleeding, so they opened both jugular veins. He was basically bled to death and tortured to death over a series of a couple of days. Now, fast forward a few hundred years, Sigmund Freud promoted cocaine as a great treatment for many things. And there are numerous ways to let blood, including leeching. There were, I think, in 1833, 40 million leeches were imported to Paris alone. So let's just make something up. This is not a real trial. Imagine someone at the turn of the last century wanted to treat hysteria, which was a kind of common condition then. And they looked at the two established treatments at the time. They said, what? One person, there's bloodletting, which is very common, and Freud promotes cocaine. Let's compare cocaine with bloodletting and see which one turns out to be better. And let's just say cocaine turned out to be more effective than bloodletting to relieve symptoms of hysteria. It would be unreasonable to conclude based on that trial that cocaine was effective, because both therapies could have and probably would have been worse than doing nothing. That is, both treatments could have been and probably would have been harmful. So, it's important when we don't know what works, it's important to compare the new treatment against a placebo. That's granted. So when we don't know, the thing is that the new Declaration of Helsinki is not talking about that kind of historical situation where we don't know what works. They're talking about current proven interventions. They say placebo controls are okay even if there are current proven interventions. So basically, placebo controls, they do possess assay sensitivity. In a placebo-controlled trial, you will, of course, I'm talking about a non-ideal, but a well-conducted trial that's sufficiently well-powered, you will be able to detect the difference between, or if there is a difference between, an ineffective and an effective therapy. But so does a trial that compares a new treatment against an established beneficial one. If a new treatment is shown to be roughly equal effectiveness or superior effectiveness to an established beneficial treatment, then we can conclude that that trial is able to distinguish between a beneficial and an ineffective treatment. So basically, it's just not true that the consideration of assay sensitivity means that we need placebo-controlled trials in order to detect the difference between beneficial and ineffective treatments. Specifically, trials which compare new or experimental treatments with established beneficial treatments can do that equally well. The next methodological reason is what they call absolute effect size. Now they say only placebo-controlled trials provide a measure of absolute effect size. Of course, in a trivial sense, this might be true because a trial which compares a new treatment with something which is established, we obtain the effects of the new treatment relative to the established treatment. We have to make a further inference to determine how much more effective the new treatment is compared to placebo by comparing it with the established one and then the established one with previous trials against a placebo. On the other hand, or so the story goes, a placebo-controlled trial provides a measure of absolute effect size. This is quite simple, as the figure here shows. If we have a treatment effect and a placebo effect, we subtract the placebo effect, from the treatment effect, and that difference is supposed to be the absolute benefit of the treatment. But that's just a story. Placebos do not, in fact, provide a measure of absolute effect size because placebos don't always behave the same way. That's a typo there. Sorry, number one, it should be placebos do not always behave the same way. And then, oh, actually, sorry, that's not a typo. There's assumptions behind the claim of absolute effect size. One assumption, which is false, is that placebos always behave the same way. They don't. The second assumption is that placebo and treatment effects don't interact. They do. Here's an example. Joanna Moncrief did a wonderful study of so-called active placebos versus standard placebos for depression. So what is an active placebo? An active placebo is a placebo which causes one of the side effects. Now, why are they useful? Let's take depression. Now, one common side effect of tricyclic antidepressants was dry mouth. Now, let's say someone enrolled in a placebo-controlled trial of a tricyclic antidepressant, and before entering the trial, they signed an informed consent form where they had to agree that they understood that the drug, the active drug, if they got the active drug, they might get a side effect like dry mouth. But they didn't know when they first took the pill whether they had the placebo or the tricyclic antidepressant. However, after a few pills, they began to have a dry mouth. What would that do to them? That would lead them to believe, hey, I got the real drug, the actual drug. I didn't get the mere inert, so-called inert placebo. This might subsequently lead to positive expectations about their recovery from depression. They think, wow, I got the real drug. Everyone says these real drugs, these new drugs are fantastic. These positive expectations can activate the brain's reward mechanism in such a way that the body produces its own chemicals like serotonin, dopamine, which can reduce depressive symptoms. On the other hand, if the placebo contained some ingredient which caused dry mouth, that couldn't happen. So of course, what Joanna Moncrief found was that placebo-controlled trials that involved active placebos had smaller effect sizes than placebo-controlled trials, which had standard placebos. So this is just one example where it is clear that placebos do not all have the same effect, and therefore placebo-controlled trials do not provide a measure of absolute effect size. But that's not all. Interaction or additivity. One assumption made is that you can add everything up. Let's look at that equation again. It looks like it's simple addition. You do placebo effect, let's say it's a 3, treatment effect is 5, 5 minus 3 is 2, 2 is the absolute effect size. It all adds up neatly. Now, that kind of additivity applies in physics. If you play billiards, for example, the forces, the resultant force can be added up by combining the two component forces. I put another example there. I'm not sure if it's a good one. In case when I talk to people who are not medical people or not, let's say, versed in physics, they might have a vodka Red Bull. The vodka might give them a slight intoxicating effect, and the Red Bull gives them a stimulating effect. And you can combine those two for the overall effect. Again, I'm not sure if those actually interact or not. However, in biology and chemistry, and by definition, therefore, human affairs, additivity sometimes, in fact, often does not work. Let's look at water. Water is made up of hydrogen and oxygen, two highly flammable gases. When they're combined, they make liquid water, which can put out flames. Let's look at you and I, people. The phenotype is a combination of genetic factors in the environment. They combine, they interact in a way. They don't combine in an additive way. That's just some general background about the assumption. Let's look at that assumption specifically applied to placebo-controlled trials. Now, if placebo-controlled trials provided an absolute benefit of the treatment, as was shown in the previous slide, I'll go back to it again. So this here where my clicker is, that shouldn't change. If I change the size of the placebo effect, this shouldn't change, the absolute benefit. But the example from Joanna Moncrief showed that it does change. Now, here's a more dramatic example. This was a trial of smoking cessation. They gave some people nicotine gum, that contained real nicotine in it, and others they gave fake nicotine gum, placebo nicotine gum that did not contain nicotine. But they had three different pairs of groups. So in the leftmost one in the slide, where you have almost, the bars are tiny, close to zero, both groups were told they had real nicotine gum. That is, the group that got real nicotine gum was told, you have real nicotine gum, and the group that got placebo was told, you got real nicotine gum. So both groups believed they received real nicotine gum. Now, in those conditions where the patients both believed they had real nicotine gum, they both groups quit smoking. They both went to almost smoking 0 cigarettes per week. However, when both groups were told, I'm looking at the two middle columns now, when both groups were told, you're getting the placebo, that is, the group that got the real nicotine gum said, you're getting the fake gum, and the group that got the placebo gum were also told, you got the placebo gum. By the way, they were both groups were encouraged to take this gum as part of the trial. Now, in that group, the group that got real nicotine gum smoked fewer cigarettes. So the drug had an effect. There was quite a big effect. But again, if these two things didn't interact, if beliefs and so on and other placebo factors did not interact, you wouldn't change the benefit of the drug. That is, what would happen if you had an absolute benefit is, when you increase the placebo effects, let's say by telling both groups you have the placebo, the difference would remain the same. This trial shows in a dramatic way that's not true. So once the shrouds are removed, and once we look deeply into what these so-called methodological and compelling and scientifically sound reasons why we need placebo controls. To remind you, one is that they say only placebo-controlled trials possess assay sensitivity. False. If the control treatment is an established beneficial treatment, then we are able to tell that the new one is different from an ineffective therapy. 2, they say placebo-controlled trials provide a measure of absolute effect size. That's also false and based on assumptions about placebos behaving consistently, which doesn't happen, A, and B, the assumption that placebo and treatment factors don't interact, also not the case. Now, by the way, we have a systematic review under consideration by a journal, and it turns out that this assumption of additivity isn't just false sometimes. In other words, I haven't just cherry-picked. Well, I have cherry-picked to show a good example, but it's not the case that that's the only example. There are, at least in domains where the condition is placebo responsive, at least half of the time we found evidence of interaction. Before closing, I'll consider a number of objections to my argument that have been raised in the literature. One is one objection from a fantastic statistician called Stephen Sen, who's also a great person and who's helped me a great deal. I'm very grateful to him. I respectfully disagree with him on this point, however, that he says, look, there's a difference between placebo add-on trials and other placebo-controlled trials. And he's correct. That's an important distinction that I make in my updated version of my publication. And here's the difference. In a placebo add-on trial, both groups receive the established beneficial treatment, but then half of them get a placebo and the other half get the new experimental drug. So in that case, there's no ethical problem because everyone's getting the best beneficial treatment. So I think it's an important distinction to make, absolutely, and the World Medical Association should make that distinction. But as an objection to my argument, I think it's a red herring. Because nobody objects to placebo add-on trials on ethical grounds. They're not unethical. I can't see why anyone would. I've not read any arguments claiming that they are unethical and they could be dismissed out of hand. Second of all, placebo add-on trials are not what the defenders of the revised Declaration of Helsinki referred to in those documents I cited earlier. Third of all, placebo add-on trials are not what's being used in practice by researchers who do trials like the one that the imaginary patient Phil was in, although it was a real trial. So anyone who uses this as an objection to the view that the revised Helsinki is objectionable, I think is raising a red herring. So in other words, it's an important distinction, yes, but to focus on it exclusively or even more than the main issues, the underlying issues, I think is misleading. Another objection is developing countries. Some of my colleagues say, hey, you know what? Sure, Jeremy. I mean, it's great that you're saying we should not use placebo controls here, but in developing countries, the established treatment costs money. And of course, they wouldn't be able to afford the established treatment anyways, so why not do placebo-controlled trials there? Well, I don't think that holds water, because first of all, for one thing, placebos are surprisingly expensive. Admittedly, not as expensive as some drugs, but because there's no economy of scale in designing specific placebos, they're often not as cheap as people imagine. It's not just like the cost of some sugar in a tablet or in a capsule. Second of all, the new drug could be harmful. So it's not like you're just giving these people a chance to benefit from a new experimental drug. You also might be harming them. I also think that because, should the drug turn out to be effective, they stand to profit greatly, that I think it could be argued it's our duty to reward these participants by enrolling them in a trial that compares a new treatment with an established one. So I don't think that the argument that we can use the developing world as a guinea pig grounds stands up to any scrutiny whatsoever. Another one, people say placebo-controlled trials are cheaper. Now, this is true in some circumstances. If you do a certain type of trial that compares a new agent with an established one, specifically a trial designed to not establish superiority, but rough equivalence, and the equivalence margin is small, then you do need a larger sample size for that kind of trial. But that's not a general objection. It only applies to certain types of trials comparing a new treatment with a established beneficial one. And it also depends on the margin of equivalence. This again is quite technical. So I won't get into the statistical details, but I point people to my publication if they want to look into it or ask questions after the talk. And it also relies on a specific type of trial called a non-inferiority or equivalence trial, which I think themselves have ethical problems. And that's a separate talk. If you want to hear that one, just contact the organizers of Kellogg and I'll do a follow-up. So it also makes common sense to compare the new one against the best established one. If I want to fly to Montego Bay, Jamaica, which sounds like a great idea given how cold and miserable the weather is outside, I don't just look at British Airways and see how much it costs. I don't just, I compare all the available options. So real evidence-based medicine should compare all the available options. I don't care if I have back pain, I don't care whether this drug is better than a placebo. I care whether how this drug compares with all the available alternatives. It's common sense. More than common sense, it's also, if you don't get the best treatment for you compared to the alternatives, your health will suffer relatively and sometimes dramatically. And we can remember Phil, patients like Phil died in placebo-controlled trials where there could have been an established beneficial treatment used as a control. So the World Medical Association needs to reverse its position, because reversing its position to the 1996 position avoids the tension between clinicians and statisticians. It's common sense. It avoids harming patients. I'm writing an open letter to them. If you want to add your name, please get in touch. Thank you very much. Please feel free I'll leave time for questions. You can follow me on Twitter and all that jazz. I'll now switch, I'll switch onto the camera. So yes, thank you very much. Can you all see me? Good, okay.
So I think I'll have a question, because we don't really have in Teams, I think that we have hands, and here I didn't really find any. I have multiple questions, so I will probably just start. Feel free to answer whichever you like.
First of all, I think there is, if you could, the bottom, there's a
Oh,
kind of a reactions. If you click on reactions,
yeah, but then there is a clapping and then okay, but raising hand I think is not one of them.
yeah, I don't mind if you clap also, it's okay.
Oh,
Yeah,
okay,
I'm good.
but that's kind of not quite.
Otherwise just shout out, or people want to raise a hand, just put a clap and I'll know it's kind of a hand.
Is it okay if I proceed, or is
Please
anybody?
do, yes, please do, yes, thank you.
Okay, thank you for the talk. I have really several points, and I'll start from the beginning because I want to ask it actually as you were talking, but then actually it also makes sense to ask now. You stated multiple times that if there is this alternative of having treatment, and why not use it? And you also said multiple times, do no harm. Multiple treatments and steroids as well, particularly probably, and lots of, because you talked also about treatment of depression and also medications used there, they do have side effects and some of them are very nasty. That's why actually here talking about that it's do no harm, statistically, yes, statistically you still of course help people more than people would be harmed from those side effects. However, for individuals, it can be that actually they would in the end be better off not being treated at all than to suffer from those side effects. That's why here the statement of do no harm, generally, yes, I think if we say that's proven treatment, that's correct. But side effects, another thing is, so that would be point one. Another one, I'll just spell it all out, personal preferences, because he also said there were those 4 cases when there was known treatment available and still placebo was used. Do you know if people actually probably decided themselves that they would rather be tested because of their personal convictions, that they would rather be tested against placebo and not real treatment? Because that would actually change, I think, a lot. And the last point, I'll try to formulate it because I really don't mean it in probably the way it may sound, but as you made your arguments in the end when making your counter arguments, I think first of all, I mean, the two of them are a little bit more contradictory, because in the beginning you said, well, placebo is, there is this argument that real treatment is more expensive than placebo. It's not always true. But then the next argument you talk again about that, you know, it's kind of the other way around, and developing countries. And what I want to say here is that it's nice to take high ground, to be on a very high horse and say, you know, we don't want to treat those people as guinea pigs, and probably even maybe label people who would suggest that as such. However, if the alternative is, and very often I'm afraid it is the case, that we just say, well, you know, we can't afford actually having those trials in developing countries, and if we have money, we'd rather do it here at home. So the alternative may just as well be that indeed, yes, that would be cheaper, much cheaper, not always, as you correctly pointed out, but it would be much cheaper just to have placebo and to have this new drug and test it in developing countries instead of nothing. Because the alternative would be those people will not enter those trials, they will not be helped at all. Because it would of course be nice if we all could just afford everything, help everyone, but the reality is a little bit different. Thank you very much. These were my points.
Well, I'll divide those into 2 points, Blair. Those great points. So first of all, you said, what if someone, for some reason, there's an established beneficial treatment, but for whatever reason, they don't like it. They don't like it, their preference. One thing is preference, one thing is resistant to. I can combine those both into the same thing. So let's talk about the simple case first. Let's say they're resistant to, let's say they're allergic to steroids for some reason. I'm not sure if it exists, but let's say they are allergic. In that case, there is no established beneficial treatment for them. So the argument there's nothing wrong with a placebo-controlled trial for them. The cases I've examined, that's not the case, because those trials, if someone's resistant, let's say a kind of antibiotics, it's not the case that the antibiotics which cause an anaphylactic reaction are established beneficial for them. So you're right, that's a distinction which I point out in the longer version, but it's a distinction, it's a clarification. But if you think about it clearly, it's not the case that there's a beneficial established treatment. Now, personal preference, that's a good point, because in that case, the same argument applies, I think. If someone they might have needle phobia. So anything involving an injection for them, even though it's established beneficial, it doesn't really work for them. Now, I think that the argument, I think you're correct. That's another important clarification. The cases that I've seen, neither of those apply because both of those are not ethically problematic. Or if someone has a religious belief, they might think that blood transfusion is not for them or something else. In that case, it's useful, of course, to do a different trial. So I think what you're talking about in the first case is a clarification, like the important clarification of placebo add-on trials. But I don't think it counts against my argument. I don't think that the argument, the objection never takes off because it's just, I don't classify those as things where there is a beneficial established treatment. So but it's an important clarification. I grant that. Good point. Now with the developing countries, if you're talking about, I mean, the drug companies make more profits than banks. If you're telling me they can't afford the drug for a few hundred people in a developing country, I don't think I'm taking an unreasonable moral high ground by saying, come on, let's give them a chance. That's my moral stance. And maybe you think I am on a high horse. And I'll admit that. I'm guilty of that perhaps, but I stand by it at the same time. And then you say, well, it's a case of they wouldn't get anything. That presupposes that the new treatment, which we compare against a placebo, will be beneficial, not harmful. Of course, we all believe and hope that these new treatments will be beneficial. But if you look at the stats, and I have looked at the stats, first of all, new treatments are as likely to be worse than established ones, they'll be better. And new treatments it's about 70-30 for placebo-controlled trials. So a new treatment, I'm talking about a large sample. I take a large sample because everyone believes that their new treatment, of course it works. We just know. But if you just take a step back and use kind of a Bayesian prior probability, it's about 0.7 that the new treatment will be better than a placebo. That means a 30% chance is not as good as, and since all treatments have side effects, it pretty much means harmful. In some cases, those harms can be dramatic. So I think that when we look at it that way, it's just the argument that, hey, we're helping people who otherwise would not have help is one side of the story. And it's important to add that, and this new treatment might have no benefit and it might harm them. So that's what I would answer. So excellent points. And then the first one, I will use that to make an additional clarification in the book chapter I'm writing. So thank you very much. Thank you. So I love questions and I don't see any hands clapping or I don't. So if it's because I don't see them, then please just turn off your mute and ask a question. No questions?
Hi, it's Marion here. I was just going to ask a little bit about your, you presented, was it the Moncrief or review, and how, the instruction alongside placebo effectively, resulted in slightly different effects being shown. And I guess I saw that and I wasn't surprised because, you've added yet another co-intervention into the mix. You've added the instructions. So it felt that for me, it didn't sort of strengthen your argument that, I think your argument you were trying to say was the placebo effect wouldn't remain consistent. But if you add another co-intervention, it wasn't surprising that it might change. So I guess I wondered if you wanted to comment a bit about that would you really have expected it to stay the same when you're adding a co-intervention? Because for me, that's the whole point, is that it wouldn't matter in the sense if it was additive or interactive, then
yes.
Yeah. So do you want to just talk a little bit more about it?
Yeah, thank you for raising that. That's important because there actually, in this case, there was no co-intervention. What was, in a way there was, but it wasn't what you said. It wasn't an additional instruction. So in both cases, everyone had the same instructions, but in one case, the placebo pill had a chemical in it which caused the side effect. So your argument still applies in a way. Yes, why would you expect the same thing? That the point is that placebos are all different. I mean, their colors can have effects. It's been proven, for example, that not proven, because nothing's proven in a kind of deep sense of proof, but there's evidence. There have been a number of trials suggesting that red pills have a stimulating effect, and blue and green pills have a kind of dampening effect. except among Italian men. Now, why do you think that is? Because in Italy, their football team are called azzurri, blue. So when they see the color blue, they get excited. So different placebos, different effects. And of course, you might say, well, hey, this means this is not surprising, because why should it surprise us that different placebos have different effects? I agree with that point. But then the claim that placebos, and just the word placebo, haven't provide placebo-controlled trials provide an absolute effect size, it's at least relative to the placebo, which is different, varies widely. That's the first thing I'll say. The second thing is that even among placebos that are the same, the effects can vary widely. So the most dramatic example I'm aware of is Dan Moorman did a systematic review of placebo-controlled trials of cimetidine for ulcers. Now, the effect of the drug compared to baseline was quite constant. The effect of the placebo ranged from 0 to 100% of the effect of the drug. No evidence that the placebos were different. So to summarize the answer to your very important point, no, we should not be surprised that different placebos provide different effects, but the fact that different placebos can be different and have different effects is often overlooked. And B, even the same placebos have different effects depending on baseline characteristics and so on, which is why, together with a bunch of wonderful colleagues, we've produced guidance called Tidier Placebo, where we encourage and try to help. Your colleague Jonathan Rees was part of the team. He's was a great help, actually, to describe what's in placebos. Does that satisfy the question?
Yeah, I suppose, the same could be said for the clinical effect of an intervention. That varies in whatever trial you look at, and that's why you do things like meta-analysis, where you expect heterogeneity of effect depending on many things. So I suppose, I guess my point of view was that it's not a surprise that they may vary a bit. That's part of life in a sense, but you can still get a relatively consistent effect or assessment of what that placebo effect is. So it was just really trying to push you a bit on that, as to whether that was really a convincing argument against placebo. I guess I was less convinced by it.
It's not okay. So let me just run if I just going to play a little bit with this a bit more. So I agree with you. So to someone like you who's very well versed in this stuff, it's not as surprising as it is to some people who just hear the word placebo and they think of something inert and so on. Now, would you or would you not agree that placebo-controlled trials provide a measure of absolute effect size?
They provide an assessment of the active ingredient of whatever measure. So I guess it depends how do you want to use the word absolute effect. I guess I see uncertainty in everything. So, there isn't, everything you do is estimating a true underlying truth, and there will always be variation around that. And so, yeah, a placebo will give you in my view, probably the most accurate measure of that underlying truth, wherever it is. But there will still be variation in that.
So I'm sympathetic to what you say. I'm just taking, they say there are sound and compelling scientific reasons. And one of the reasons they give, I didn't say it, they say placebo-controlled trials provide a measure of absolute effect size. So I haven't heard you clearly say, yes, they do. Because you might not agree with me, but I'm saying, they're saying, here's one reason. And if you don't agree that placebo-controlled trials provide a measure of absolute effect size, then you don't agree with them that they have sound, compelling reasons.
So I suppose I'm saying that they provide the best estimate of the underlying absolute effect size. Of the types of different studies we have, that's a placebo will give you the best estimate of that. So I'm probably nearer their end of the needle, maybe.
What's that?
I said I'm probably nearer their description than just to say that. I guess if comparing placebo-controlled trial versus a non-placebo-controlled trial, yes, I would agree that a placebo-controlled trial will give you a much more accurate estimate of the absolute underlying effect size.
But what about, Marion, what about interactions, which are, as far as I can see, altogether ignored? interactions between placebo components and active treatment components, where different baseline characteristics can lead to dramatically different differences. So you're saying how could the difference should, if it provides a measure of absolute effect size, the difference, the benefit of the active ingredient over and above the placebo effect, whatever that placebo effect is, shouldn't change. But
yeah, it should be consistent, and that's why
it's not. I can promise you, in cases it's that I can promise you it's not. I provided one example, the nicotine cessation. I'm happy to send you. Would you be convinced if I showed you my systematic review?
Well, maybe, but I guess what I was saying was the one where you had the added instruction. That's a coincidence. That's an extra.
Both groups get the same instruction. Both groups were told this is a placebo. It's not added.
No, but were they not told that? And one was also told it was active, and one was told. Maybe I just misunderstood your example.
Both were told the same thing. If it's the absolute effect size, if this is the effect size of the drug, then I put this on top of that. That's the absolute effect size.
Yeah, sure.
Changing the underlying thing shouldn't change this size. It shouldn't change, but it does. Moving this up and down shouldn't change. It does. I think that I'm going to send you my systematic review, and if there are it sounds to me like if I can convince you that there are interactions, you might reconsider the view that placebo-controlled trials provide a measure of absolute effect size. But now I want to change the subject with you. Let's say you're right. Placebo-controlled trials do, and sometimes they do, because sometimes there aren't interactions, and they do provide a good measure of absolute effect size. Sometimes they do. What if that's the case? From a patient's point of view, I don't care. I want to know what's the best thing for my low back pain compared to all the other available alternatives.
Yeah, and I suppose it goes back to the underpinning, and I'll stop now because I don't want to hog the conversation. It goes back to having an underpinning evidence base that you know what's a proven treatment. Or everything else you need to know is a proven treatment. And I guess that's, if there is a proven treatment, that does change the ballgame a little bit. The issue is what's proven.
So I'll tell you what we did in my review where I said that the case of Phil was not unique. What we did was we took all the placebo-controlled trials published in the top 5 medical journals in 2015, and we looked at the, we searched to see whether there was a systematic review of randomized trials of a beneficial treatment according to a systematic review of randomized trials for that condition. Now, of course, you can dance and have opinions saying, no, of course, yes, there was a systematic review of randomized trials that showed a benefit, but I don't like systematic reviews, la, 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 la. So what's important is that in the cases we found, people are shocked to see this, and maybe you don't believe that it actually happens based on but they're shocked to see that in the case of I told you that steroids for liver disease, it's not that controversial. There's no reasonable disagreement in the scientific community that the steroids do reduce the risk of death. So it actually does happen that there are placebos used when there could be proven beneficial treatments. But you're absolutely right that just because something is well used, it doesn't mean it's beneficial. It could be like bloodletting or like leaching or like cocaine for hysteria. We don't, and we are probably overconfident about the effects of our treatment. But
sure, thank you.
Hope you don't mind that I've enjoyed this discussion. I get excited sometimes. I hope you don't mind that we're bouncing ideas back and forth, but I've enjoyed those questions. Thank you very much.
Oh, sure. Let others come in.
Yes.
If nobody has a pressing question, I would like to ask, because I had this question before, and I noticed that you keep on doing that. I mean, jumping here and there. My question is, do you not think that it's maybe very important to actually separate really clearly treatments for psychiatric, psychological issues and non-psychological? Because you're making this example, for instance, I want like good treatment for my back, or we're talking about liver disease, and effects of placebo there, and when we're talking about psychological issues, are very different. And these are also very different problems that probably should also be in this regard treated differently. To be honest, I would have much less of I agree with you generally, first of all, but I would have probably much less of a problem. And in fact, I would rather support actually use of placebo instead of certain medications when treating psychiatric disorders, psychological. What do you think?
What's your background?
I'm a mathematician. That's why here as a second note would be, when we talk about clinical trials here, I also have a huge problem actually with data, how it's all measured. That's why I'm also like maybe more with Marion.
So first of all, I'm going to give you an answer you might not have expected. I think that the distinction between psychological and physiological is difficult to maintain. No, I've never met anyone who can name me one single thing which is purely psychological. Nothing is purely psychological. Every thought you have has a physiological correlate in your brain. That's the first thing. So as a general background point. Second of all, psychological, we mistake. Let's give an example. A placebo-controlled trial that Marion, I'm sure, is familiar with. They did a bunch of people, vets in Texas about 20 years ago. They had such bad knee pain, they were not responding to maximal drug therapy for at least 6 months. And then the x-rays showed clearly, physiologically, the x-rays showed damage to the cartilage and the bone on the knee. Damage you could see, you could show them and you could see it. But the doctor, he was a doctor for the Houston Rockets, a famous basketball team in Texas. If anyone plays basketball, they'll be familiar. It's like, let's say, a famous football team in the UK equivalent. Everybody knows. So he found that some people reacted differently with the same x-ray or very similar x-ray. So he did a placebo-controlled trial to fix this physiological problem with the knee. With some of them, he did the real debridement and so on, arthroscopic surgery, where you kind of clear away the fragments and clean it up so it doesn't cause the pain. For others, he would just cut and sew it back up, and they thought they had the real surgery. Or they thought they might both, it was double blind. They thought they might have the real or might have the sham. Now, the sham worked as well as the real one. And then a group at Oxford, Marion might even be an author, I'm not sure, a systematic review of sham-controlled, placebo, sham surgery-controlled trials, 57% showed the no benefit of the real one compared to the placebo. These are physiological problems. Then the last thing I'll say, sorry, Valeria, is that for some psychological problems, they're quite serious. We have known treatments. If someone is suicidal, you want to have a high dose antidepressant. That works. It's a so-called psychological problem, and yet it would be, I think, a miss at the very least to offer them a placebo control. However, certainly I would say that now that I've disagreed, now I'll agree with you. In some cases where the ailment is mild, so one example they use to defend the Declaration of Helsinki position is, let's say, mild depression, which I'm not saying is not serious, by the way. It can be very serious, but it's a mild depression where there's no kind of risk of someone doing self-harm or harm to others. Mild depression and SSRIs. In that case, people say, well, we should still use placebo-controlled trials because, we're not really withholding. We know that other SSRIs work for mild depression, but their benefit over and above placebo is so small, we can never really know in that trial if it would have been better or not. So we might as well just do a placebo-controlled trial for this mild so-called psychological condition. To me, as soon as they admit that for mild depression, they can't tell whether the so-called established treatment is better than a placebo, that means we don't really know the benefit, that the well-used treatment is beneficial, which brings me back to Marion's point. And I think there is actually a case to be made, and many scientists do dispute whether antidepressant drugs are beneficial for those with mild depression. They all have an effect, but cocaine has an effect too. It doesn't mean we say it's effective. That's my very long answer to your question.
Thank you.
You must know about. Bye, Marion. Bye. So yes, you must know about interactions. But before, any other questions? Is Therese?
I just wanted to say hi because my background is educational assessment, and I just wanted to have a lunch hour in my busy schedule listening to something which was completely out of what I'm usually doing, because in my research in education, as you can imagine, we hardly are allowed to set up any experiment where just one research group, one student group is offered anything because of the ethical issues. So I just find this really interesting, but I think I just wanted to say thank you for the presentation and also for dressing up for us, because I think that's what we need during this pandemic times. And if you had any time at all in the end, I think I would just, including the shoes, appreciate that. No, I've been discussing with some friends who happen to be part of the vaccine trial in Oxford. And I appreciate you might not want to discuss that or not, but one of the things which actually came up was some of the critique from European researchers around the use of placebo in the Oxford trial. And since some people I know has also been volunteers in the Oxford trial, still not knowing whether they have had the placebo or not, we had some ethical discussions around that. And yeah.
Well, I've written about that in the conversation actually. So I know many people nowadays, you're right, it's a dangerous topic to raise. If you mention vaccines and you raise any questions whatsoever, there's a risk someone might accuse you of being an anti-vaxxer. So I should.
Not at all. I'm so happy. I'm going to take it. I'm actually just.
I'm not saying you. I'm talking about myself. So I'm just to be clear. I'm
yeah.
not anti-vaxxer.
No, absolutely. And I'm my agenda around it is also basically I'm with international friends, families in US. I'm actually thinking about it from a democratic point of view. I'm seeking information, talking to people who do not want to vaccinate. And I think that's so important because it's also about how you communicate to people who has not had the privilege of being in school as much. They don't have higher education, and you still want to convince them that, yes, you can pick up headlines in newspapers criticizing this vaccine in Oxford. Yes, now Norway and Denmark has not approved this vaccine for people over 60. You still should actually take the vaccine. And I'm telling everyone, I'm so happy. I'm now taking it 20th of March. I'm telling everyone.
Well, that's wonderful. And now I'm inviting someone called Maya Goldenberg, who's written a book about vaccine hesitancy. And she's giving a talk in, bye-bye, Tansy. And then on, I think it's May 2nd. And I'll be putting it on my social media.
Yeah, please do.
So the vaccine trials are interesting because one of the vaccine trials, I think it was the Oxford one, as the placebo, they used a different vaccine. And why they do that is to preserve the blinding, because the placebo does not cause injection site pain as much as, so they give a different, I think it was some other vaccine we've already had, which is kind of wouldn't cause any harm.
Yeah.
When they give the vaccine, when the placebo is a vaccine, it causes the same rate of injection site irritation.
Yep.
Which preserves the blinding. So it's good for methodological reasons.
Yep.
The problem is that when they then say, does the vaccine cause infection site irritation? How do they calculate that? They compare injection site irritation in the placebo group with injection site irritation in the vaccine group, and they're designed to be the same. They say, look, there's no additional injection site irritation in the vaccine group. Therefore, it doesn't cause this adverse event. And that's a problem. So there's no perfect solution. I think that, and of course, nowadays, politics is everywhere. So the fact is that the UK did a wonderful job with the vaccines. Some countries in Europe did not. And it's hard to believe that they're not trying to take revenge. And that's a point that Maya Goldenberg makes. Before, when there were more publicly funded vaccines, these issues didn't arise because there was less need for conspiracy beliefs. Yeah. So Jonas Salk, when he made the polio vaccine, he could have patented it, but he said, you can't patent the sun. And right away when he said that, the public trust, people bought in immediately. But that's a much wider issue, and I'll be led by Maya Goldenberg. So, well, yeah. I think I'm gonna thank you so much for saying thank you, Teresa. It's good to feel appreciated, especially on Zoom. Thank you
No,
all.
I really enjoyed it.
I appreciate the questions. I'm going to use all the questions to revise the chapter in my forthcoming book. Thank you, Wesker. And I wish everybody a lovely weekend. For those of you who are mothers or have mothers, happy Mother's Day for Sunday.
Have a lovely weekend. Thank you.
Bye for now.